first annual MS Symposium on Staten Island that's patient-centric. I want to welcome everyone here today. I'm Dr. Allan Perel, Director of the MS Center of Staten Island and Chief of Neurology at Richmond University Medical Center. Today, I think it's just fitting that we just think for a moment about the veterans. Today is Veterans Day 2018. And well, I was thinking about what I was going to say today, and I'm really talking about people who have MS, people who treat people with MS. It truly is a battle. It's a war, it's a battle, and we've made tremendous strides in this regard. Our center is now in its 26th year, and I wanted to say thank you to the staff at the MS Center who came here, so I want to say thank you all for coming. Debbie Manero, who's our office manager and leader, and Trish Abruzzese, who put this event together, so I want to say thank you. I want to bring up Dr. Daniel Messina, who is the president and CEO. And just for everyone back in the room, we're actually taping this today for my TV show called Conversations in Medicine. So you see Dan in the back, and thank you so much. But Dr. Messina came up with the idea of doing this. We spoke when he first came in. He's done a lot of work with MS. And he says, Alan, when are we going to do an event for MS patients at Richmond University Medical Center? We've done a lot of work with the hospital and our center. We really are one unit with regard to rehab, inpatient, infusions, things that really we work and we partner with them. And I really have to say, Dr. Messina has done so much work on his own in the field of MS, being on the board of the National MS Society for many years, and helping establish one of the biggest MS centers in New Jersey. So with that, I wanted to say a few words to us and really say thank you so much for everything he does.
Good evening. Thank you for that nice introduction. Happy to be here. I'd like to congratulate Dr. Perel, Susan Perel, Dr. D'Angelo for bringing us together. As Dr. Perel has said, the world of MS has been something that has been something of my professional life, but more importantly, a big part of my personal life. My mom battled MS and she was in her late 20s. With chronic progressive, and the unique thing about MS, it's as opposed to many other illnesses in this world that we live in, is that it really is unfortunately a disease of the family unit. We become closer, and we are really together in this battle, as opposed to other things that medical conditions and things like that. I think. If there's one thing I learned from all of my years on both sides, and especially helping my dad battle this disease, was that, again, it's a family challenge. But I can tell you the future and the breakthroughs. I spent a number of years on the national board. I also was the chairman of the New Jersey chapter for MS. And then, as Dr. Perel said, when I was leaving New Jersey after 30 years to come back here 4.5 years ago, one of the things that was important to me was I always had this vision of developing an MS center, in large part driven by my mom's intense battle with MS. And I'm very happy that we pulled together and developed a wonderful program at Centra State in Freehold, New Jersey, the Linda Cardinale MS Center. But we are doing great things here, and I'm really excited about the continued growth and expansion of the services that Dr. Perel leads. As I mentioned a second ago, one of the things that I was exposed to on the national board was constant updates on what is happening on the research front. And I could tell you when Mom was diagnosed, there were 2 drugs that I remember. Valium and baclofen, and that was about it. Today, there are all these disease-modifying agents, and it's a whole different world. As a matter of fact, one of my favorite stories, if there's such a thing as a favorite story, was my dad had an intense focus on trying to battle this, and this goes back into the 70s, 60s, whatever. And I remember us going into Chinatown and looking for herbal remedies for MS. And acupuncture, when acupuncture, we didn't even know what that word was. And then reaching out to the famous football coach for Notre Dame Parsegian, okay, whose daughter, does that name ring a bell to anybody? Whose daughter battled MS. And so we have a long history of this disease. I think I will say it never beat us because it brought us closer together. And I think the future is definitely bright with the research that's being done on both sides, on both the relapsing remitting side as well as the chronic progressive side. So I'm happy to be a part of you guys and a part of the family, if you could call it that. And I want to thank Dr. Perel for his fight with us on this, in this battle with MS. But we are, I think, winning that battle little by little. So I think the future is bright. I'm happy if there are any questions that you may have of me. I'm juggling between two schedules right now, but I'll be here for a few minutes, but I'd be happy to answer any questions. I also will say, I just came back from a goodwill mission in Puerto Rico with the board of the Greater New York Hospital Association. We went to some of these challenged areas in Puerto Rico after the hurricane. And I finally got to spend some time on the plane. One of the things that that you will hopefully eventually see is an article that I've been working on with Reader's Digest, very scientific journal, but a great venue for stories about life. And one of the things I hope to see eventually published will be the title of the article is When Healthcare Hits Home. So I've seen it on both sides, being in my professional life and, more importantly, the battle with mom. So I will, yes, please.
Dan, could you comment, I'm working so intimately with the hospital and you, about the relationship, so many of our patients need visiting nurse services. And maybe some of the things that we're doing individually or with groups that are out there.
Sure. So, one of the things in healthcare that has evolved for the better has been, I think, an identification by institutions like ours, the opportunities to continue to partner with people. And, we were very good in the hospital world about thinking everything revolved around us and we had to create everything. But the one thing that has really, I think, evolved over the last several years is really partnering with providers, partnering with community-based professionals. And one of the things we've been working on is a stronger partnership with the VNA of Staten Island in particular. Although we work with a number of home care agencies in particular, the VNA of Staten Island has been a partner that has been working with us more closely, and we've established a preferred provider relationship with them. So that is something that, again, continuing to develop expertise and a stronger relationship will allow us together to provide home-based services that are needed for patients for different things that come across their life. So happy with that. And also just on the general front, lots of things happening here at Richmond University Medical Center. Aside from lots of new faces coming on board and building on a great medical staff that we've had historically here, lots of new programs and services that are evolving, including the construction in the first quarter of this coming year in 19 on a new emergency trauma department. We're very excited about that. The emergency department is the front door to the hospital, to the front door of every hospital. And a number of other projects that will be added. We're in the midst of adding 240 new parking spots to the campus. We're very excited about that with some adjoining properties that we have. And so lots happening here on the front. But I think at the end of the day, all these projects and things are great, but I think what really carries the day here at Richmond University Medical Center is the incredibly committed staff and the family atmosphere that exists at this hospital. So that is probably one of the things I'm most proud about, is the commitment that we have here at the hospital to you, our patients, and our community. So with that, I'll turn it back to Dr. Perel, and thank you all. Pleasure.
So we have an all-star cast tonight. This is a world-renowned group that if I have this talk, whether it's here in Manhattan or anywhere else in the world, these people can get up and give these talks. And I think we're going to be very, very lucky to listen to them. I have my wife, Susan Perel, who's going to be speaking about MS and its relationship to the family. And Jack D'Angelo, who's Chief Medical Officer of Sativia, very cutting-edge talk on medical cannabis. Interesting enough, when I decided that I was going to talk about an update on MS, and many of you have heard me speak, you sort of say to yourself, what are we going to talk about? Am I going to talk about the 13 different type of agents that are out there for MS? And I'm going to talk about what might be out there in the next few years. I think we're going to talk about MS as a whole, and we're going to talk about some very novel, interesting things. We know that just for everyone who's here who wants to learn a little bit about MS, is that multiple sclerosis is an immunological disorder of the brain and the spinal cord. What does that mean? It can affect anything from the top of your head to the bottom of your feet. And I'll give you an example. People with MS many times will come in with numbness in their hands and feet. So your feet are involved. Your vision's involved, so we're all the way up to your eyes. People have facial pain, problems with going to the bathroom, moving your bowels, urinating, sexual issues. So anything in the world that you could think of, multiple sclerosis can have an effect on. It's very heterogeneous. It means that people get different types of disorders. Some people have very mild MS, and about 10% of people we say have benign MS. Just don't know who those people will be. And people are at different stages. People could be very early on and look very good, thank God, and that's what our goal is. And sometimes people are not doing as well. And I'll tell you, because of industry, because of education, because of the MS Society, because of research, we've come a long way. A statistic that you have to know, and Dr. Messina mentioned before, there were 2 medicines out there, and none of those medicines he mentioned were disease-modifying therapies. So before there were disease-modifying therapies, if you were diagnosed with MS, you had a 50% chance of needing a cane within 15 years. And about 50% of being in a wheelchair within 20 to 22 years. Now, someone diagnosed with MS, the odds are about less than 1 in 10 that you need a cane in 15 years. And much, much lower than that with regard to needing a wheelchair. So we've really come a very long way with regard to treatment. We're going to talk about the different types of MS in a few seconds, and there's always that, as you notice, the iceberg slide. What does that mean? Iceberg, you have this big glacier, rather, and underneath it's bigger than on top. And why is it underneath so much bigger? Because the good part is I can't tell who in this room might have MS. I can't tell in my office when I give talks to hundreds of patients all over the country and even all over the world. I can't tell. There was a story, I gave a talk in Massachusetts recently, and there was someone sitting next to me. Nice man, we were talking, and he had a cane. And we were talking and talking, and then finally I said, "No, how long have you had MS for?" He says, "I don't have MS, my wife does." I said, "I saw you had a cane." He said, "No, I hurt myself skiing last week." So you can tell, and we can tell. But the people who have MS know. There's fatigue, there's cognitive issues, there's a lot of things that are involved. There are about 750,000 people in the United States with MS. Women get MS about 4 times more commonly than men. And we're seeing cases on a daily basis. At our center, which we take care of about 12 to 1,500 patients, every week we diagnose someone with MS. Syndromes that look like it, blurred vision, and these are fancy words, facial pain. Do you know that thought MS was a painless disease for generations? MS was first described by a gentleman named Charcot, a French neurologist in the 1870s. And it was thought to be a painless disease. The people thought that people with MS don't have any cognitive problems. All wrong. We have people who have a lot of pain. More than 50% of people have pain. The immunology of MS, what happens? Your immune system goes awry. So instead of us recognizing that the covering of the nerves called the myelin, which lets signals go across the nerve quickly, we think, our body thinks that that's foreign. So we lose tolerance, we lose our self. So are there any other diseases or disorders that we know that that happens with? Yeah. Think about rheumatoid arthritis. People get swollen joints because the body misrepresents it, doesn't realize that it's not part of yourself. Think about someone with psoriasis. The skin is thought to be foreign. Crohn's disease, various thyroid disorders, something called Hashimoto's thyroiditis. Fancy word, but if you think about it in a group, as many people sitting in here, someone's got thyroid problems. It's not uncommon. So the body sometimes mistakes part of ourselves and doesn't realize itself. And that's how the immune system works. And there are these T cells and B cells. There's something called lymphocytes, or something called a white blood cell. And when they go awry and they attack yourself, that's when things like MS occur or autoimmune diseases occur. And there are a lot of autoimmune disorders. Who gets autoimmune disorders more commonly? Women. People of childbearing years. Hormonal basis has a lot to do with it. And how do we know that? Think about pregnant women. Someone's pregnant, there's hormones that are being made to protect the baby from being attacked by the mother. Remember, your baby's got different hair, different blood, different skin. So that's where the hormonal basis, and that actually would be somewhat protective. And someone would say, why don't we make someone pregnant all the time? And the answer is there was a trial used in medicine called estriol, and it works. It's not a cure, but it's very hard to tell anyone that they have to stay in a pseudo fake pregnancy state for years. It just doesn't work. There's a lot of swelling, a lot of problems. So we're playing around with the immune system in order to get people better. And this is a real busy slide, so anybody who really knows this has to go, we have to go over this at one time. Why did I put that slide up? To show that I'm smart? To show that you guys are smart? What the heck? To sort of impress you guys? The answer is, these are all different things that cause MS, different steps in the immune system. Your MS actually doesn't start in your brain, it starts in your blood. And it makes these T cells and B cells attack myelin. And when they going around the body, they actually go into the brain. When they go in the brain, they find myelin and they start dividing and activating and cause this moth-eaten approach. And we make the myelin not work so well, so signals can't get from one place to the other. So if I go like this, my brain on the left side of the brain is telling my index finger to do this, and very quickly can go here. If I slow down the signal, it doesn't work as well. And we sometimes use the analogy, if anyone's from Brooklyn or goes to Manhattan a lot, the express train and the local. Is there anything worse than going to Manhattan on a local on the weekends? Nothing worse. You had to be in Brooklyn, you had to know that. The express train is, you skip all those little stops. That's what myelin does. It allows us to go get one signal from one place to the other and skip those stops very, very quickly. And that's really what becomes abnormal. That's why we have blurred vision, weakness. So if I want to do this, I won't be able to with someone with MS. I'll do it slower. It'll be clumsier. We won't be able to do it as much. But why else did I put the slide up? Put the slide up to say some really smart people could figure out every step that's in the cascade of causing MS, we could block. I could give you a medicine that will reduce the number of white blood cells or lymphocytes that you have. Therefore, you get less inflammation. I could give you something that'll make the white blood cells not get into the brain. It could be stay outside and more into the blood, less inflammation. I could give you a medicine that makes DNA not multiply as much, not replicate as much, and therefore you're not going to have as many dividing aggressive cells. So everything here is a step to therapy. Now, all this has taken years and years to get there. And everything that we see here is now coming to fruition with new medicines. And we're going to talk about new things in MS in a couple of moments. So update on the diagnosis of MS. Here's an interesting comment. We sometimes diagnose MS too commonly. So if someone came into me and had trivial head trauma or a nose itch and we got an MRI, there's sometimes we see little white dots in the brain. These little white dots don't always have to be MS. And sometimes we're not sure what they are, but we do try to figure out what they're not. And clues that something is not MS, it all depends if they're round versus oval, if there's no little scars around them, if there's no enhancement, which means when we give a certain dye, we don't see it becoming white around it. And we sometimes do get these little abnormalities in the brain. And nobody wants to have one. So I say to them, you don't have this little brown spot here. You're not supposed to have that brown spot, even though I've been in the sun for a lot of years. But we still say it's not normal. In the same way, a lot of these things really don't mean that much. People with migraine headaches will have these little dots. And we've had all kinds of different words of what they are, non-specific T-cell abnormality, T2 abnormalities, rather. And what's interesting about these little dots is sometimes you wind up in the neurologist's office. Someone gets an MRI for a headache, and we see these things, everybody's worried they have MS, but there's certain characteristics that we look for. And the next slide, this was a patient with a migraine headache, and these are the ones that really look like MS, and they look different. And if you look over here, see these white globular areas, and we see on the second slide all these different things, and you can actually see someone's nose all the way to the back of the head. So whenever I'm in the office and we put a DVD in or a disc in order to see it, my staff wants to look at it with me and see if there's anything that they could glean out. And sometimes they see things that I don't see on the picture, so it's always important to see. But those are those white areas that we're seeing up there. Those white areas are areas of inflammation. When you have areas of inflammation, it causes the brain not to function as well. The problem with inflammation is it leads to degeneration. Sometimes it even happens simultaneously, that you have degenerative process with this, and that's where people go on to need a wheelchair, to need a cane, to need a walker because of the degenerative process that occurs. And these are just ways of looking at these pictures, where they are. Some are near the cortex of the brain, some are right near the ventricles, where the fluid-filled pouches are. Some are in the brainstem, which will make you off balance. And gadolinium, there's been a lot of talk about this. If we're going to be cutting edge, we'll talk about, does everyone need contrast? And I see neurologists in the group here. It's always interesting. If you do things on a regular basis, basically on a yearly basis for people with attacking or relapsing MS, you probably can get away without doing with contrast many a time. Sometimes we do it to see if our medicine is working. And here's the powerful sentence. The MRI is a biomarker. What does that mean? In the old days, it used to be just for diagnosis. Someone comes in, you think you might have MS, let's get an MRI, diagnosis them. That's one thing, that's really great. What else is it? It's also a biomarker for how you're doing. So if I give you a medicine for MS, one of the 13 different categories that are out there, and I get an MRI 6 months later, and your MRI looks worse, much considerably worse, and you feel fine, you're on the wrong medicine. And we have enough medicines that we're allowed to change now. We're able to move things around, and we're able to get things into a way to find the right medicine for the right person, to reduce the degenerative process, to reduce disability, and for patients to function well. MS misdiagnosis, and these are just slides to bring up here, that a lot of people are not diagnosed properly. That sometimes too many people are diagnosed, or sometimes people aren't diagnosed quickly enough. So it's really have to be on your toes. And we have residents here, and I tell the residents every day in my capacity here at Richmond University Medical Center, is if a young woman comes into your office or your clinic with numbness in their hands and feet, you better do a very good exam, ask a lot of questions, and make sure that it's not MS. Not everybody, it's stress, it's a little bit, they're tired, there's family issues, there's stresses in life, there's carpal tunnel. You have to take those complaints very seriously, because nobody wants to come to your office or your clinic unless they have something that they're concerned about. Then we did some revisions to all the criteria that we did, but really the basic part is MS is an inflammatory process. Inflammation means attacks, relapses, all this exacerbations, all the same word, meaning that there's an inflammatory part of it. And then what sometimes happens is that we become progressive, which means there's less reserve in the brain, more degeneration, and that's where people are left with more noticeable deficits. And patients tell me on a continuous basis, when should I stop my medicine? The answer is, if someone's got function, I don't stop their medicine. So if they're able to walk, talk, enjoy life, do things, swallow, all those things are important. When someone might be bedbound and really can't do anything and really very debilitated, sometimes we will. But a vast majority of people, I recommend stay on medicine for a very long time. And even I don't know when the end sentence of that is. So these are just some revisions, and we talk about people having attacking MS, relapsing MS, inflammatory MS, or more degenerative processes. We're just over time, there's not that much more reserve. And that's how we think about MS now more. It's an inflammatory process and the degenerative process. Brain reserve, the longer, and here's an interesting concept. Everybody knows about diabetes, and diabetes is not MS. But diabetics, where is the first numbness you get with diabetes? Your feet. Why do you get it in your feet? Because your feet are further away from your spinal cord than your hands are. And there's a whole theory about with MS, why are the legs involved earlier? Because the length of the nerve cell is stretched so far at that point that it puts pressure on it, that any damage will affect the legs first. So the legs are almost affected first, and that's one of our new theories with regard to the length of the nerve cell. Let's go over therapies. There's a lot. And I'm not going to talk about them that much. And why am I not going to talk about them that much? Because we know about them, because we're using them, and you have to go to a doctor who knows about all the medicines. Everybody really doesn't have to know every single one, but you have to know most of them. Why? Because if something doesn't work, you don't want to stay on a medicine that's not working. As I said, whether it's clinically, how you're doing, with number of attacks, disability, or even with regard to MRI. And we've gone a long way. In my practice, which is now 26 years old, we, in the beginning, were putting patients on chemotherapy for MS. Why? Because these were inflammatory diseases, and we want to reduce the number of blood cells that we have, these white blood cells. Now, for the last 10 years, I've not had one patient on chemotherapy. And And that's a powerful statement, that we're able to treat with these new missiles called monoclonal antibodies to affect MS patients and to reduce inflammation very dramatically. Think about when you think about immunological treatments for cancer. We don't always need chemotherapy. And again, it's not my field of expertise, but we're using the immune system to help fight cancer in so many different ways. These are just some new medicines that are out. There's something called ocrelizumab that was used for relapsing MS in different studies, and it showed some very dramatic benefit. What was unique about this medicine was that it works actually to slow down progression, even in progressive MS. So that was the first medicine to show that it works both in relapsing MS and progressive MS. But even in that stage, once you have progressive MS, all it did was it slowed it down. It doesn't reverse it, but really patients are still affected with this very dramatically. There's another medicine that's going to be coming out. I'm just mentioning some new things that in the future will be coming out. These are medicines that block the exit of what's called B and T cells out of the lymph node. So you keep them more sequestered in the lymph nodes, and the word lymph node means where they keep the lymphocytes. And that's why keeping these inflammatory cells sequestered in there, you get less of an inflammatory response. This is another medicine that's going to be coming out next year. And one of the other medicines that does very similar things was just showed some benefit in pediatric MS. There's another medicine that's being looked at, and when we say phase 3, it's not out. There's a medicine that's being looked at, but it didn't show a benefit. And why do I put that up? We put that up because we want to talk about medicines, not only that work, but that don't work. Because sometimes our hope is out there for medicines that we've heard about, and sometimes they don't work. This is a new agent called cladribine, which eventually may be coming out. It's available in Europe right now, which is an oral agent, which may show some very, very promise. So we talked about there are different oral agents, but what's unique about this is you give this medicine 10 days 1 year, 10 days the next year, and then you don't have to, many people don't need the medicine for years afterwards. So there's some effect on reconstituting your immune system or changing your immune system not to be as inflammatory. And this was just some points that they had about it. This was just the name of it. But again, these are medicines that are coming out. So clinical trials, and we have a lot of different medicines that are being used. And sometimes they work, sometimes they... Here's an interesting story. There's a medicine called biotin. Everybody knows about that for hair growth, hair health. Biotin showed benefit in a big study with progressive MS. They did the study a second time, didn't show the benefit. What do you do? So they're still looking at it. But sometimes we don't always find it. There's a product out here from a company called Biogen called Anti-Lingo-1. That's the really holy grail of what they're looking to do, what we're looking to do. Everything I've said to you so far, anti-inflammatories, make your immune system different ways. This is a medicine that actually makes the cells of the brain, something called an oligodendrocyte. It's just a myelin-making cell. Start making stuff. So you start making myelin. So if you make myelin, you could repair the process. And they had some very promising data in the beginning. They've had a few glitches right now. But that whole concept of being able to use a medicine that helps repair the brain is now really what the next step is. The last thing, if you look at HSCT, really just talks about stem cell replacements. And there's been some data showing some benefit with reducing the inflammatory response. It doesn't get people better. And that's where we can't really regrow things as well as we can. So, as well as we'd like to. So it's very interesting, all these new agents. You know, there's a medicine that's called natalizumab or Tysabri, a very, very robust agent that's been out for over 10 years. That really that dramatically changed how we treat people with MS. It's a medicine that helped really arrest the disease, slow it down dramatically. And now we've got some other medicines similar to it that work different ways. But the idea of where we've come has been so remarkable that I really can't say it enough times. Comprehensive MS management. Everybody wants to know what we can do holistically. What's the number one thing? I have vitamin D up there, so that's not the answer. The answer is stop smoking. Remember, MS is an inflammatory disease. What promotes inflammation? Smoking, right? So it's not a good thing. You're coughing. Think about all the soot, the tar, all that stuff. See what happens? I get violent when we talk about smoking, so stop smoking. 2, low-salt diets. High-salt diets are pro-inflammatory. And 3, having normal levels of vitamin D is important. Because they found in certain studies, if your vitamin D level is low, the risk of you having worsening MS goes up. Those are the kinds of things we talk about holistically. So sometimes you say, well, the doctor never told me what else to do. It's vitamin D, normal heart health, normal weight, things of that nature. Stop smoking, say it again, stop smoking, and normal salt or low salt diets are beneficial. So there are some things that we've looked at. Some of the things like biotin, we're not sure. It was very high doses and it didn't show a benefit the second time, but they're still looking at it. And that was just a slide to remind me about vitamin D. And fall risk, we have to be careful about falling, and that's where physical therapy is such a major part of this. So sometimes I say here, and I'm going to talk about glamorous agents, medicines that are in Europe, what can I turn off the immune system. So if you go to a health food store and they say I have MS, what are they going to give you? Something to build up your immune system. Does it work? No, I want to make your immune system dampen. I want to modulate your immune system because your immune system is too hyperactive. So that's where sometimes the concept of what we do holistically doesn't always work. We want to reduce infections because if someone has an infection, all your white blood cells start multiplying, even the ones that attack the myelin or MS. Exercise is of course important. Fatigue control. About 95% of patients have fatigue. And it's not because they can't walk well. They actually did a study taking people with rheumatoid arthritis versus MS. They said, well, they could each walk a block. Who was more tired? The people with MS. Why? Because it's brain chemistry, because it's a brain disorder. There's an inflammation of the brain. Why, if you have a cold or the flu, do you feel tired? Because it's inflammation of the brain. That inflammation goes all over. That's what makes people feel so tired. So importance of MS symptom management, which we don't talk enough about. Cognitive impairment, what do? Tell you to go online and do luminosity, brain games, crossword puzzles, keep mentally active. Now what is the one thing that doesn't make you mentally active? It's watching television. It's too passive, it's not an interactive event. Also being physically active, walking. And they did a study comparing people on treadmills and comparing people walking outside. People outside were much better off. Why? Because there's bumps, it goes up the street, in New York City especially, there's a lot of issues. You go on your treadmill, it's too level, it's too perfect, and you don't watch other people coming at you, cars, there's a lot of issues and things you have to do. Treat depression, helps people tremendously, and people with MS do have a higher risk of depression. And we want to keep people doing as well as possible. So with that, I want to say thank you. We wanted to make all these talks somewhat short. We wanted to talk about some really cutting edge things that are going to be coming out in the next few years. Every time I give one of these talks, everybody says, when's the next medicine coming out? Soon. How are our medicines working now? Well, but not good enough. And just want to say one thing, how many medicines do I need for MS? I need one. We need a cure. If I don't have a cure, how many medicines do I need? There are 750,000 people in the United States with MS. I need 750,000 medicines because everyone is different. What side effect-wise, oral preparation, how they're feeling on it. Everybody is very unique. So with that, I'm going to say thank you. We're going to come up to our second talk.
Okay. Hi, everybody. I'm Susan Perel, and I'm a social worker on Staten Island for, it's embarrassing to say, over 30 years. Oh, okay. And I am the social work component of the MS Center of Staten Island. And it's a pleasure to be here and speak with everyone. When I was thinking about doing this talk, I sort of stole the slide from the MS Society, which I am a part of. I've worked with them for many years as a consultant, and they have a lot of different slides on different subjects, and I thought we could just use it as a background to some of the things I'd like to talk about, which is, I know the title of my talk is I think it was something about I have MS, but MS doesn't have me. And which is basically our way of saying that this something that, like a medical diagnosis, shouldn't have to define my life, shouldn't have to define me, who I am. I'm more than just this one thing. I have hobbies and interests and families and family and my years of education, growing up, cultural, the different aspects. And my MS diagnosis, just like any other part of me, it's just a small part of me, and it doesn't define me. There's a poet that I always think about when I was in social work school. We spoke a lot about it. It was William Blake, and it's called The Doors of Perception. And he said he had this whole concept, which is very interesting because the cognitive behavioral therapy that we do today, in my mind, is really based on some of these old thoughts. And I always look back to it. And his idea was there's the known and the unknown, and in between are the doors of perception, which also, there's another book written by a man with, in the 1950s, Huxis was his name. And he called it the gate between heaven and hell is the doors of perception. So in other words, how we perceive the thing in our life, the things that come to us, is going to define our journey. And this is a journey. We're here for a short time, and we will try to make the best of it with all the challenges that are thrown at us. We don't know why things happen in life, but and I don't know if we'll ever know, but we try to make the best of it as best that we can and survive with what we have, the tools that we have. And that's my role, basically, is to show people that there could be, we could turn things around. There's always a silver lining or something positive in all the experiences in our life. It's just trying to figure that out and make it so that we could survive and it could work for us, and to try to be positive. This is a very big thing for MS treatment today in the social work field, is to try to stay positive. And we call it wellness, well-being, fitness, health. It's all the same. It's all the same road. It's all the roads to get to this place of trying to be positive and to feel good about ourselves with whatever the gifts we have on this planet for the time that we're here. So one of the things we'll just go through very quickly is why is wellness a high priority for people with MS? They talk about things like diet, exercise, emotional well-being. And when someone's given a diagnosis that could be, devastating or shocking at the beginning, we all react differently depending upon how we've learned to cope in life. And some of us struggle to find the strength to take care of ourselves. But the thing we look for is to start every morning anew. We all make mistakes or take a step back, but we try to wake up anew and to treat us like ourselves like you would treat your best friend. You'd want your best friend to treat themselves. So to try to eat well, to try to rest, to try to take care of ourselves as best we can. And emotional well-being, of course, is part of that. So that's basically what I'm going to, talk about. I'll try to make it quicker. Okay, so this was interesting. Wellness is a lifelong journey through which people develop awareness of and make positive choices about their behavior, lifestyles, activities that enable them to lead their best lives. And this could be true for all of us, whatever challenges we have in life. Wellness is personal, multidimensional. Okay, so we talk about these priorities, what makes us feel well and healthy and all together. And we talk about diet and exercise, which is more like the physical well-being. You eat well, you exercise, you have endorphins, you feel good about yourself. When you can move, when you can accomplish things, emotional well-being, work and home. I think everybody needs a purpose to sit home and be ill. We all, people who are ill, can't work or mostly, but to have still some goals, things that interest you. Maybe you can work from home, or not to lose that, because that's in this society, if you don't work, if you don't participate in work, you're at a loss, I think, unless you have very strong hobbies, because it's a very big connection to the outside world of who we are. Spirituality, whatever that means, it doesn't have to be any kind of certain religion, a belief, or any kind of spirituality. Could be planting a seed and watching it grow. That to me is a very spiritual thing, knowing there's more out there than us that we feel connected to. I think for me at least, it's doesn't have to even be religion. It could be anything that inspires us to feel connected to something greater. It puts things in perspective. You don't only think of yourself as your illness or what's plaguing you, but that there's more what's beyond. Relationships, always trying to surround ourselves with positive people. If you leave, this is like a rule of thumb, if you leave a friend and you don't feel right, you feel down, or you're irritable, you probably have to think about that friendship. And especially when you're under stress with the chronic illness, being with positive people and positive relationships is a very important thing. And also cognitive health. If you're not feeling, if you feel like you just can't get it together, just something maybe you talk to your doctor about. And like Dr. Perel said, like, you know, games, try to keep your mind sharp. When I was reading recently about like cognition, they were saying even if you take a walk, to try to take a different route every day, because your mind has to adjust to seeing new and different things, and it starts to work, it starts to, creative juices start to flow, where if you take the same route every day and your mind is used to looking at the same trees and the same houses, it goes into like a malaise. So always trying to challenge yourself, try to do, you know, if you've always gone to one place to do all your shopping, go somewhere else. Try to do different things. Even something simple as that can spark thoughts and memories, and you know, it just perks you up a little bit. Try, if you always wear black, I always tell people, if you always wear, if you look at your closet and you have all black, buy something with color, because you maybe are not feeling so happy. Like try to, you know, do something different. Okay, so these, I don't really know much about diet. I'm not a physician or a scientist, but we try to eat healthy. We all know the basics about healthy eating. Try to be active. You know, I always tell our clients, get up in the morning, get dressed. There are, you know, many of us struggle through these moments during the day. Take a shower, put yourself together, try to get out, try to have something to do every day, and try to control our stress level. There's a lot of different ways we could talk about trying to control our stress level. We live in a very stressful world, and MS also affects young people, and they have families, and they're struggling financially, and there's a lot of stress. And to try to control stress as much as possible. Social relationships, go to the party. Don't stay home. Go out with your friends. Go try to do things. You know, don't limit your world. We tend to, there's a tendency that we have when things aren't going well to keep our world small so we feel we control it, and it actually is more stressful. You know, to get out, take some risks. You know, if you have friends that push you to do things, those are good friends. Because you need that. You feel better. You go out a little bit, get your mind off things. And just, you know, they also talk about not smoking. I think some of these are obvious. Alcohol intake, you're on a lot of medicines, or have chronic illnesses. We have to try to watch drugs and alcohol. Okay, these are just basic things about other things that exist with MS that causes stress or reduce the quality of life. Let's talk about just, you know, taking care of yourself. Sleep is a very important thing. We often get into a routine when we're home a lot, of going to bed late and waking up late. And sleep is very important. We try to be, have been studies done by psychologists that to stay in a sleep rhythm is very important, because it's like your circadian rhythm. There's a lot of issues related to that, and to try to stay, like people that work nights and they're out of sync with the rest of the world, it could lead to depression and people feeling very stressed. So to try to stay in a sleep routine is very important. It could help, because also with MS you have a lot of fatigue, so sleep is very important. Okay. So these are the things that we talk about just to maintain overall health. It's very important to see your primary care doctor and be honest with them. We have a tendency to say everything's fine, whatever. Just be honest with them and tell them what's really going on. We can't help you if we don't really know what, we're not mind readers to see what you're really feeling and what's really going on with you. Even if it's a small thing, it's worth mentioning. And my point is that emotional well-being is as important as physical. Because if you're not feeling good about yourself, we tend to do self-destructive things. We're down on ourselves, we're less active, we're not eating the right things, and it snowballs into physical as well. So that's really important. The thing is to get to know yourself and to know what makes you feel better, the people that you surround yourself with that make you feel comfortable and better about yourself, and the things that you do in life that are outlets, whether it be artistic or travel or whatever it might be, just to learn about yourself in your own journey. We tend to do a lot for other people, to try to be a little, when you have a chronic illness, you have to try to learn to be a little selfish. They say limit sugar. I'm not a dietitian, but these are common sense type things, I would think. The MS Society promotes all of these ideas. Exercise, the good thing about exercise is that it makes you sleep better. That's like one of the things. Not only is it an outlet and it makes you feel better, but it also makes you sleep better. And it puts you on a better cycle. So it's good for depression. I had surgery a few years ago, and my doctor told me within an hour or two of surgery to start walking, not only for physical, but for mental health, to feel like you're a person again, you can function again, that you're capable again. And I think he had a good point. Okay, so this things Dr. Perel talks about, I'm not a dietitian. These are the different diets you had asked. Somebody asked about the gluten. The MS Society are promoting these diets as MS diets. So I think somebody mentioned the gluten and some of the other diets. The swank diet, they talk a lot about that. At the swank diet, at the MS, I think there's a slide about that later. They talk about it a little bit more. My advice would be, whatever makes sense to you, whatever isn't too difficult. Like if you love a certain kind of food, don't kill yourself. Don't make yourself crazy unless your doctor tells you to recommend it. And if it works for you, to do it. If it's not working, why put yourself through being restricted on a diet? Of course, with your doctors, okay. These are some of the barriers to exercise. You're weak, fatigued, your coordination. The thing to do is to set specific goals, short-term, very specific goals, and make them attainable in a time frame. So to say to yourself, I haven't really been walking, I'm going to walk around the block within 2 weeks after some short trips. And this type of thing, like set very specific short-term goals that you know are attainable for your medical condition. And if you need to have somebody with you, this is a kind of a disease where you need support. You need people around you that are going to be there for you. And things like yoga, swimming, bowling, gardening, any of those things. It's still you're being outside. We want you outside. We want you part of the world. Things like this are. It's the word. It makes you feel whole. It makes you feel capable and better. And certainly have some fun while you're at it with things that you enjoy. The guidelines. Okay, so these are some guidelines about exercise. Again, this is not my area of specialty, but certainly everyone needs to get some exercise with their doctor's guidance. When we talk about MS with physical therapy and exercise, similar. I'm just going through some of these. Okay, so this is something that I would talk about. In the face of a chronic, often progressive illness like MS, many people tend to focus primarily on their physical health and may neglect their emotional health, which is an essential component of your overall well-being. And that's my main point today, to try to say that I feel that your emotional well-being is just as important as your physical, and they're connected, whether it be MS or any kind of physical challenge or medical challenge that we're having. Okay. So this is some of the things we're concerned about, just to go through them. Depression, history of mental illness. So in other words, if you have a history of depression or bipolar disorder, having MS isn't going to be a good thing. It's not going to make it better. So it's like an added challenge. But there are medicines and support, and our patients do very well. They actually do very well, and we monitor them closely. And we also, I don't want to ever talk about any of these issues without mentioning the caregiver. We see caregivers not taking care of themselves. I know my ladies in the office know this better than anyone. They get ill. We need care. We always have to be very aware of caregivers, and they have to take time for themselves and It's very stressful to be a caregiver. We've all, I think, been caregivers at some point in our life. It's not an easy road, and it can be very overwhelming. So there's always the support groups. There's, you know, in our office, we always spend a few minutes talking to the caregiver. How are you doing? How's it going? You know, what do you need? We try to be there for them and acknowledge them as well. It's a tough thing. It's not everyone is meant to be a caregiver. It's it's a whole science to this. In my field of social work, that some people sort of very easily lend themselves to the role of a caregiver because of whoever they are, their personalities, whatever their background is, and other people really struggle with it. And something that as healthcare professionals we also have to be very aware of. So, yeah, and social isolation. We talk about this a lot, especially with diseases like MS, because because it's hard to get out, it's hard to get dressed for certain people, and it's difficult, it's like a struggle, so you tend to avoid the things that are difficult, and we need to get people out and be with other people, to socialize. We're human beings, we tend to be very social people, and you feel better after you're out in public with friends or family. You feel like you're a part of things. You want to feel like your old self. Okay, so one of the most common symptoms is depression from MS, and also they talk about the care partners are prone to depression. It's very treatable. There's different therapies today. There's medication, talk therapy, exercise. We are recently starting in the office a machine called the TMS machine, which is like with this transmagnetic stimulation, and it's one of the newest treatments for depression. It's something we could talk further about. We're always looking for non-medication related treatments for MS and for depression, because it's such a common thing in our society today. We could talk about why that is, but that's another talk another day. So, you know, the one thing that people are saying in my field in psychology and social work is that one of the reasons that depression has gone up among the population as a whole is because people look for happiness in life instead of meaning in life. And happiness is fleeting, whereas if you look for meaning in life, it sort of gives you a purpose, and it's more long-lasting. It's just something interesting to think about. These are the kind of things. He thinks about science and medicine, and I think about meaning in life, as opposed to and poets from 500 years ago. Okay, okay, so let's see what else we have here. That's another thing. Meditation, prayer, meditation. We just want people to, it's like a rediscovery of yourself. When you no longer always have your body to push you through life, you kind of have to delve deeper inside to figure yourself out. It's a process, it's a journey, but life is a journey. Aging is a journey also, and you can rely on your physical body less when you age, and to think about what's important to you, what makes you feel good, who you are. People join book clubs, anything to reach out to others. There's so many options today with social media, and I mean, it could be used for such great things, to find other people that you could relate to. It could be very positive. Peer support, it's nice to meet with other people that are going through similar things, for caregivers and for people with MS as well. It's very helpful. If you contact the MS Society, there's like a whole group of different support groups. We even have some on the phone for people that can't get physically to different places. And there's also we started an adolescent support group for children of people with MS. After school, they kind of really, they got together, they liked each other, they formed like a bond. Children of people with MS, they're going through their teenage years, which I thought was a great thing, to feel socially connected. I don't want to take up all your time. This is similar to what we were saying, intellectual health, work and home, trying to keep a sense of peace and harmony, trying to really work at keeping yourself positive and mentally stimulated, and doing things that are meaningful. There's the meaningful thing. looking for meaning in life, whatever that means to you, wherever you find it, and for health and well-being, enjoying the JCC or one of these, clubs. They have a lot of classes about health and well-being. It doesn't have to be swimming laps and killing yourself like that. There's other things to do in this realm. Healthy habits. Oh, this is the goals. Okay, so this is what they talk about a lot, is that when you make healthy new goals, whether it be for sleeping, for eating, to make them specific, measurable, achievable, results-oriented, and time-based. And this is what I was talking about as an example before. I'm going to walk around the block within 2 weeks. It's achievable. And make goals very achievable. Because if you make them too lofty, then you can't achieve them, and it's sort of a waste. So we looked even smaller goals, even eating healthy. You could use this framework for changing your life in different ways, and it's very simple. However, whatever you're looking to work on. And cannabis, Dr. D'Angelo is going to talk more about that. This is like a big thing now for chronic illness, and especially for MS. People are really talking about it. We want you to be on the cutting edge, to be educated, to feel like you're in control of your life, your future, what you're dealing with. Be educated. Talk to if you don't feel comfortable talking to your healthcare provider about what you're going through and all the options, then maybe you have to look for someone that you can have a good rapport with. It's very important. And we talked about vitamins and all that. It's not my field, but it's I'm sure a good idea. Okay, so resources. There's something here that I wanted. The MS Society has a tremendous amount of resources. They're very helpful. You call them, they know me. When you call, if you say you're one of our patients, they'll help you. There's all different studies or different services that are options. Oh, so there's this whole thing that came out of Harvard. So I've been reading about this. It's called the Happiness Advantage, and it's this whole foundation of positive psychology. So this whole thing, it's very similar to what I was talking about before. So if you take a situation, it could be like, let's say you get into a little car accident, and try to, instead of framing it, oh, this is terrible, I'm having a horrible day, to try to frame it positive and say, well, maybe that little car accident prevented me from getting into some worse thing that was going to happen later in the day, and maybe in a way it taught me patience, or I was rushing and that would have maybe ended in something worse. And this is the whole foundation of this type of psychology. And believe it or not, there's tremendous data that self-talk on the positive actually changes your brain. It changes how you perceive the world. It changes your mood. And this gentleman, Sean Aker, he's the one that was at Harvard for 12 years. He was a professor there, and he came up with this. The book is called The Happiness Advantage. It's very readable if you want to pick it up. I think parts of it are online, or there's interviews with him on YouTube. Very interesting. That this is that's the other thing. It's a very short program, so you don't need to be in therapy for 20 years like the old Woody Allen movies. Like, I've been in therapy 15 years, another 10, and I should be, doing pretty well. It's not like that. It's very goal-oriented. It's very specific, and it just teaches you these techniques to think positively. And it sounds kind of like pedantic, like very simple, but the reality is there's tremendous research on this, that it's very effective. And my thought is whatever works. If you could try to make us feel positive. Any day that we're not sad and burdened is a better day. If you could, anything that works for you. So I would look into this. I found it very interesting. That's about it. And the resources, always the MS Society is there for you. And our office is always there for you if there's anything we could do. They have a lot of resources. And that's about it.
Now we come to what everybody wants to hear. Who doesn't want to hear about cannabis, medical marijuana? We have an expert here. We're going to talk about things that are very cutting edge. And the concept comes down to is it for everyone? No. Is it for a lot of people? Yes. Is it for a lot more people than probably are taking it? Yes. And we're going to hear about different parts of it. And I hope Dr. D'Angelo is going to talk about CBD and THC and hemp and different things, and really try to get us up to par on where we are. And as a neurologist, a physician is one of the, there are a couple of hundred, I think, in all of New York State, maybe a little bit more, that I do give out medical marijuana, medical cannabis. I'm a big fan of it, and I've learned a lot from Dr. D'Angelo, who's a great friend and someone who I've known for many, many years now. And I really am honored and thrilled to have him speaking to all of us tonight. So Jack, please.
Hey, good evening, everybody. Thank you. My one big challenge will be to stay behind the podium. I'm kind of an active Italian speaker, and so it's a little bit hard for me. But this is a great topic. It's an exciting topic. I'll give you a little bit of history behind the topic and what brings me to be the person talking about it. I'm a physical medicine and rehab doctor by trade and profession, and have done that for 25 years plus. And so in the past, my role in relationship to disease was always been to do a lot of what you've kind of heard here tonight. My big focus was all about function. I was not the guy that needed to worry about the challenges behind the treatments. I was the guy that really worried about how to get you back to living the life you want to live. For instance, you have a disease state. It has, it's a title. But really what drives patients to seek help is, I can't walk to the end of the block. That's really what drives patients to seek help. Patients don't go to a doctor because they have a title of a disease. They go to a doctor because that disease is affecting the way they're living their lives every day. And so much of my life was built on what Susan talked about here, really. The words, positive psychology. I would constantly challenge my patients. Don't use the word can't. Can't is a really big word, right? Use the word I'm challenged. Use the word it's hard. But don't use the word can't. Our language is so important about how we are and who we are that it becomes a really crucial element in the conversation. And some of that is what brought me to cannabis, because about 4 years ago, there was a group of families that went to the state and said, hey, this healthcare system is failing us. We're not getting the results out of it that we personally need. And we would like to try these options. And most of these people were really driven by their children. And funny thing about politicians, they can ignore a lot of things, they never ignore a child. So they paid attention and they listened. And this moved a conversation forward, not just in our state, but presently 30 states in the country have medical cannabis rules and regulations. And some of that is a little bit bothersome to me, because in most of these states, the politicians have indirectly decided what disease states are treated by this medicine. And I think politicians should do politics and doctors should do doctoring, and that's a little bit interrupting in our care of patients. But to make a long story short, it brought a topic that was actually a very common medicine in American history up until 1942 back into the mainstream conversation. And presently our challenge is twofold. One is we have state rules, we have federal rules. The federal rules say cannabis is still as bad as heroin and LSD and is a controlled substance in that regard. Therefore, it has no medical purpose. And because the federal rules say that, it really limits the amount of research and the associated activities that have been conducted in this area. The state rules are basically saying within the state we can have these kinds of changes and we can do this new treatment. The challenge is people don't live in one state, people travel, people do things, and as a result of that, let's face it, over the next few years things will change dramatically on a federal level, because as they say, this cow is out of the barn and is not going back in. So what brought me to it is I was so impressed by these people. So our state senator on Staten Island, Diane Sedino, is the one who brought this legislation forward at the state. And I had known Diane working on other projects, and she said, just get more involved, get more involved, get more involved. So took out my plane ticket, went to Colorado, which was the early state in this, and the first medical conference I went to, no one owned a jacket. Everyone that was there was in these tie-dye t-shirts, and there was about 3 doctors walking around the room, and I thought, I don't know if I should be here or not, but I was there, I paid my fee, and kind of sat through the process. What I love about cannabis today, now 4 years later, is that it's a wellness tool, all right? This is not designed to replace your medications that you're using for your MS, and that's what we're going to talk about tonight. This is designed as an adjunct. This is designed as a little bit something extra, because what we know about cannabis is that our body produces what we call endocannabinoids. 2 of them in particular, these chemicals that they produce, are very similar to the chemicals in the cannabis plant. So these 2 are, one everybody knows about cannabis is something called THC, right? That's the euphoric part of cannabis. That's the part that is the misused part of cannabis, so to speak, okay, in the community. And then there is the CBD part, and the CBD is where the money is in this room, all right? The CBD is a very potent anti-inflammatory. There are CBD receptors throughout our body, all along the nervous system, all along the peripheral and the central nervous system. The only place where there are not CBD receptors are in your brainstem, which is why no one can die from cannabis. And so that's the first take-home message about that. How does cannabis work? We're not going to get into this in great detail, other than to say what separates cannabis is it has what we call a retrograde effect at the synapse. So the space between where nerves communicate. All right, normally what happens, 2 nerves kind of come together, they kind of secrete a chemical, it goes across, it says, hey, to this one, and this one goes, oh, I recognize you, and it sends a signal down the nerve. What the cannabinoids do is they react in what we call a retrograde manner. They're fine tuners. That's the way I think of them. So think about your radio when you're trying to get that channel, right? You're just kind of using your fine tuner to just get it right. So what cannabis helps to do is those things that are just off a bit, that our traditional medicines are working on, just not getting it quite right. Cannabis helps to get it quite right. So I remember 4 years ago when the Compassionate Care Act in New York came out, I had reached out to the National MS Society and said, I'd like to come in and give talks to your patients about the Compassionate Care Act. And they went, oh no, we can't talk about that. We can't talk about that. They just weren't ready. 4 years later, recently in Tennessee, there was a consortium of MS groups that met together and have gone through kind of this rigorous trial of looking at all the studies that have been done, and basically have come to the conclusion that cannabis certainly plays a role in management for the MS patient. Anybody in here has tried cannabis? You don't have to be shy because it's legal, right? So, okay. So I want to talk about distinctions, because most people have tried cannabis that a friend gave them, okay? I'm all about standardization. And that's what the medical cannabis program in New York State and in all of our other states has given us. It's given us standardization. That means every time you take it, it's exactly the same as the time before. That means I can help dose it for you, I can help guide you, we can help fine-tuning that right dose for you because it's the same every time. So that's an important thing to recognize that's different than when you're just going next door to your friend who's kind of giving you something to smoke. 2, in New York State, we do not have flower. We have processed oils of the plant that are basically oils in capsules that you can swallow. They're oils in vape pens that you can then inhale, or they're tinctures that are absorbed under the tongue. Why don't we have flower? Because flower is something you would have to smoke. And after we've spent 30 years as physicians convincing patients not to smoke, it's a little bit odd for us to tell you to go home and smoke, all right? Even though there have been studies that have demonstrated that smoking cannabis does not necessarily increase your risk of lung cancer, it can certainly increase your risk of emphysema and COPD, because what it does is the smoking of cannabis introduces tar into your lungs, and that can be problematic. Ironically, cannabis is a bronchodilator. So it opens up your airway. So when you take cannabis in a capsule or in a tincture or even through a vape, it's actually opening up your airway. So that's a very interesting side point by that. Another side point just to remember about vaporization, because everyone worries about vaporization because, right, we've seen all these commercials where these pens explode in people's pockets and things. All right, good quality, like everything else, is important. Having a good pen is important. But more specifically, all that smoke that comes off of a vape pen is not secondhand smoke. It's water vapor. There is no risk to the person standing next to you. And so if they go into work and their drug test is positive, it's because they used and not because of your vapor. And so it's an important thing to remember. One of the studies recently done that they looked at this consortium was really looking at utilizers. And it appeared that when they did these polls and these studies, and one of them that the MS Society conducted, there was something between a 50 and a 66% use of cannabis by MS patients. Now, I think that's very high. I think, let's face it, it's a survey. So who are the people who are going to take the time to respond to the survey? The people who have something to share. So that's why it looks that high. I think it's high. But the more interesting thing is when they look at these drugs, and we have some comparison. So we have prescription THC, right, that we can prescribe to patients. And unfortunately, it's it's 100% THC. It has no other part of the plant in it, right? This is what we use for people who are on end-stage chemotherapy. We use it for cancer patients. Most patients hate it because it's so high in THC, it makes them non-functional. And here's the key that we're always challenged by, right? Pain relief and function. All right, one of the things we've seen happen in the use of opioids over time is that people actually lose function. And so, therefore, that's not a solution. We're not helping anybody by taking them down that road. And one of the things that we've recognized with cannabis is that it has marked improvement by the patient in terms of their gait and their spasticity. But when we try to use objective measures to measure that, so as a rehab doc, we have all these objective tools that we pull out of our bag to really measure your function. When we use those tools, your function is exactly the same. But the patients note a significant difference. It's very interesting. Almost every one of my MS patients will tell me their gait improves. Almost every single one, okay? I can't tell you that every single one of them tells me their pain is gone, but every single one of them tells me I'm walking better, all right? And so that's a positive thing, right? Even if I can't objectively measure that, that's positive, because what could be behind that? We heard Susan talk about depression. The sister to depression is anxiety. Everyone lives in anxiety. When you have a chronic illness, as much as we could say, don't let this illness take over your life, it kind of does, doesn't it, right? You have to worry about so many different things. You have to worry about, is my insurance covering this? You have to worry about, what if I run out of insurance? You have to worry about your job because, hey, if I can't keep up my work at my job, I might lose my insurance. And so then you have this other thing, right? The thing when the days that you don't feel good. So now, how do you plan an event? Because that might be a bad day, right? And so it's all of these things, while we talk about it, anxiety becomes a very big part. The perception, the anticipation, the concern, am I going to be out and have an issue, really impacts on what we allow ourselves to do, doesn't it, right? Because we think about it. And so maybe some of what cannabis is doing is reducing anxiety, a bit, and by reducing anxiety a bit, it allows people to not be stopped by their own perception of who they are. And so that may be what it does. This is a great little study looking at smoked cannabis. And interestingly enough, the federal government has been giving out cannabis, I think, since 1972 or 3, or since then. And it was part of this program that started under President Nixon, really looking at, ironic, life is so ironic. But basically, there was this farm they had in Maryland. They were growing cannabis. It's like the worst strain of cannabis imaginable by today's standards. But they had a list initially of 15 people in America who received rolled cigarettes from the federal government every month, forever. Now I think they have 2 patients left on that program that are still getting cigarettes from the federal government. And the whole goal of that was that these was designed for those patients in end-stage disease. They really weren't looking to treat wide varieties of disease, but really end-stage disease. To make a long story short, as we move forward, the irony of that, right, is that the federal government has this program, and at the same time we're still arguing about whether or not this is beneficial. Also to point out that the studies that were completed during the Nixon administration were completed in terms of trying to change the classification of cannabis. And so they were looking at to find out whether or not it was safe enough to be declassified. It was, all right, according to their own data and their own studies at the time, but politics got in the way politics has colored this whole picture. Cannabis and MS for bladder issues has not really been shown to be dramatic. Interesting. Small studies. We still kind of recommend that people can use it, right? Because there's a certain element of your bladder dysfunction that's really spasticity or related, and so that there might be some goal for it, because that's really where cannabis stands out, is in spasticity. It makes a huge difference. And so when we talk about the usage of it, because one of the things that it gets a little bit confusing to patients is, well, what should I use? Right? So you go to a doctor. Here's the way it works now, right, in New York State. If you're interested in using medical cannabis, you go to a doctor who's certified by the state to prescribe medical cannabis, and he will write a recommendation based on whether you fulfill one of the 14 categories that the state has specified it can be used in. And that's really what happens. And then you go to the dispensary, and there's a pharmacist in the dispensary who kind of asks you the appropriate questions and helps to pick your product. The one-to-one products are the products that seem to work the best. So when I say one-to-one, is we have products that are based on ratios of what we call CBD to THC. Now think about this for a second. The more THC there is, the more euphoric it's going to feel. The less THC, the less euphoric. The more CBD, the more anti-inflammatory it is, the more anti-anxiety producing it is. And so, you know, we all know these stories of people in college who smoked cannabis and got really paranoid and were afraid that someone was going to go chasing after them. That's because they had a rec product that was very high in THC, very low in CBD. Nature is good. If the product is more level, that paranoia or anxiety doesn't happen. All right, so what we know, we can lessen the euphoria by increasing the amount of CBD. All right, and we use that a lot. But so where we start patients, where I always start patients, is really on a one-to-one basis of CBD to THC. If it's someone who is in a lot of pain, I might over time increase their dose of THC. And we do what in the industry is called microdosing, which means we're trying to find the least effective dose that improves your symptoms. That's the personalized nature of it, right? It's not going to be the same for every single person. It's going to be different for every single patient, and that takes a little bit of time to find your dose. So that's pretty much what we do. I often recommend that patients are really using 2 products when they go to a dispensary. A long-acting product, so something like a capsule, and using a short-acting product, whether it's a vape pen or a tincture. The tinctures are dissolved right under the tongue, so they give you that same rapid onset of action. They work within 2 to 3 minutes. But they're short-acting. They only last like 2 or 3 hours. So it's good to have something long-acting and then short-acting, very much the way we manage asthma, for instance. Okay, we embark on that kind of a road. This drug that they talk about here, Sativex is one of the only approved drugs that has a combination of the cannabis extract in it. So it is the one that's been a lot of studies done on. It's not what you're getting when you go to a dispensary, okay? So Sativex is what would come from a pharmacist. Again, the suggested ratio is 1 to 1. How frequently you should use it, that varies from patient to patient, right? So what I will tell you, what we know over and over again, there is one side effect that we have to be concerned about for cannabis, right? And that is it affects your cognition. So if you're an MS patient who is feeling that fog all the time, is having a hard time focusing all the time, you're going to want to be a little bit more cautious with your dosing because it can affect your cognition. Over and over again, what we see is that it always affects cognition. All right, so even though it might be giving you relief, it can affect it. Why I prefer plant over and you see Canador as a cannabis extract. Again, we're talking about here on the THC doses. We dose on the THC level many times because that's the one that will really affect people's cognition and people's euphoria, so we really want to minimize that. But what sets the plant apart from anything you get from a pharmacy? Why is this so different? And we believe there's power in all the elements of the plant. So the CBD types that are in the plant, and there's about 100 to 120 different chemicals in this plant that interact with each other that make it so unique. So some of it is the CBDs, some of it is the THCs, some of it is what we call the terpenes. The terpenes are those part of the plant, any herb that you might use, that give it its smell, its texture, so to speak, right? We believe very strongly that the plant works in its totality. So our job as processors of the plant are really to take the whole plant, bring it into an extract that we have standardized, and still manage to keep its identity that way. That's something that is very hard for a pharmaceutical company to do because they don't work on multi-levels of chemicals that way. And so it becomes a little bit harder for them to do. And also it becomes a little bit harder for them to trademark, right? And if they can't trademark something, it's a little bit harder to make money off of your investment. And so that's the other thing that plays a role here. This talks about cognitive function. So these were, most of these studies you're going to see, and there are lots of them, but they're small group studies. They're studies with 20, 25 patients at a time. But basically what you can see here is all of these people noticed that there was a cognitive difference on information processing. Okay, that's important because you don't really want that effect. You know, the biggest, growing group using cannabis in general are my 60 and over patients, all right? These are people who are like babysitting their grandchildren. So they do not want to be out of it. They just want to be able to bend and play with the kids and get back up again and not look like they have to call for some help to get back up again. So that's an important thing to remember is when people talk about cannabis, we are not talking about getting people stoned. In the medical cannabis world, that is this. We don't want that, all right? We want to give people better function. This is a study that was really done on spasticity. And again, you can see that muscle stiffness improved by almost twofold in the group taking the cannabis compared to placebo. Now, these people are still taking all their other medicines. So again, I want to make sure everyone gets this. This is not in lieu of your other medicines. We've talked about why the other medicines work. We've talked about the difference that the other medicines have made in the last 30 years. We don't want to go back to 30 years ago. This is an adjunct. This is the fine tuner. Some of our medicines have side effects, that this may help with some of the side effects that you're experiencing with those medicines. So that's what this is about. This is a synthetic cannabis derivative that we use all the time, dronabinol. This was a study that was looking at to see if dronabinol had any effect on the progression of MS, and in this study it didn't. And this was a pretty good sized study, but it didn't show. And as Dr. Perel pointed out before, we have studies that sometimes show us some great initial results, and we all start jumping up and down and get excited and think this is the holy grail. And then we discover, a year later, well, no one else has been able to duplicate these results. And so those are probably not reliable studies. We are in early phases of studies in this, and these studies are all going to be small because of the limitations posed on doing studies right now. This is just a composite of stuff that was put together by the American Academy of Neurology that basically was looking at MS and the adjunctive therapies, and basically, again, shows that patient perception of their spasticity and of their pain improves, but not necessarily reproducible by us on any of our assessments. And I've got to say, and you might say, well, does that mean it doesn't work, that we can't objectify it? I don't know the answer to that, okay? I do know that if we continuously rely on measures and don't listen to patients, then we're not treating patients, we're treating measures. And I think while with doctors, we kind of love data, we kind of love looking at it, the truth of the matter is, it's really always about the patient. And so we have to keep coming back to that, because the patient really guides us on what works for them. I hope someone else is looking at time, because I'm really bad with that. This is another large review that was done. And this study found that patients taking cannabis were likely to achieve a 30% reduction in pain. All right? Listen, THC, of course, it helps with pain. The question is how much, and how much can someone tolerate? All right? And it's finding those right combinations. Here's what I will say, is if you find that you are needing to take narcotics or opioids for pain control, what cannabis will definitely do is allow you to take less of them and still achieve pain control. All right? And that's important, right? Because there is no health benefit to your narcotic or your opioid. No one's telling you a story that these are anti-inflammatories, okay? They're not, except managing your pain. You also get the health benefit of cannabis, and the health benefit is that it is a potent anti-inflammatory medication. And one of the challenges over the next few years is going to be for us to really harness that in a way that really helps our patients. Cannabis strains. So if you go to some dispensaries, they only sell flower, and flower has weird names like Pineapple Rush and Sour Diesel and Girl Scout cookies and strawberry this and as a doctor, I'm like, come on, I can't work like that. So we don't really focus on strains so much. We try to change the conversation, focusing on percentages of CBD and THC, because those are the principal elements in the plant. and not really get focused on the strain or whether or not it's a sativa blend or whether it's an indica blend. They do different things, but we try not for that to be the focus in a patient conversation because it's hard to standardize that conversation. So we need to have, if we're talking about medicine, it needs to be reproducible, right? Every single time, it needs to be the same. So when your grandchildren are coming over and telling you, oh, I'm so happy you're trying this, okay? It's funny, that's what my seniors tell me. My grandchildren are so excited, all right? You know, you're not smoking their weed, okay? You're not using theirs. You're using a medical equivalent thereof. So, take-home messages from this. Cannabis does play a role in MS. And I know before we had talked a little bit about the other things, okay? So, you know, where diets are concerned, and Dr. Perel touched on it briefly when we talked about the biodiversity of the bacteria that live in our GI tract. 5 years ago, if you had said that, people would have looked at you like you were a total loon. Okay, and I've been one of these people in my profession who's always kind of stepped out of the box a lot. All right, so I kind of feel really vindicated that suddenly we're having real conversations about the bacteria that have symbiotically lived in our bodies since the beginning of time, and that we have done a really good job at erasing over the last 100 years. And we've done that because of low-grade exposure of antibiotics in all of our foods. We've done that because of changes in our diet. We've done that because of changes in the balance of our diet. And so now we have conversations that are grounded in science that before were just held on that alternative stream about the immunological benefits of having good genetic diversity in our GI tracts. And so our challenge is really going to be to harness that. So anything that fights inflammation in a way that it's not as destructive is going to be a benefit, all right? And that's why cannabis has been so helpful, right? For years, everybody recognized cannabis in nausea and vomiting. And so we know it has a benefit there. So it's another area that will change over time. And the last thing I want to mention about that is other complementary therapies like acupuncture and herbs can be helpful. The problem with most herbs is that they are not standardized. So if you could think of cannabis as an herb, but we're trying to standardize it. And if herbs aren't standardized, it's a little bit hard for us to know really what people are getting, and therefore it becomes a little bit harder to recommend it. Acupuncture, another tool. I've been a practicing acupuncturist for 25 years. It doesn't change the progression of your disease, it can change the symptom of your disease, right? It help relieve a symptom. And so that's an important thing to remember. And that's equally as valuable, right? Because what we talked about earlier, what I started off with saying is people aren't driven to a doctor because they have a diagnosis code. They're driven to a doctor because there's something that is interrupting the way they're living their lives. And that's really what drives them. So I'm going to end my talk there.
I want to say thank you for coming out. This was our introductory event. We'd like to maybe do this on a yearly basis. And it's a pleasure. Thank you all for coming out.